If you're waking up at 2 a.m. and 4 a.m., there are three things happening in your body that almost no doctor connects in the same conversation. Most men over 50 assume it's the prostate, so they ignore it, manage it, or accept it as part of getting older. But the prostate is only one piece, and if it's the only piece your doctor is looking at, every night of fragmented sleep is quietly draining your testosterone, and most men never connect the two. Write this down. There are three problems running at the same time in your body right now, and I'm going to show you exactly what they are, how they connect, and the three questions worth bringing to your doctor before you accept any single explanation for what's been waking you up. Drop your age in the comments right now. Just the number. I want to see who's watching.
This is education, not medical advice, but it may be the most important conversation you have this year. I've spent years reviewing the research on men's health after 50, and the pattern I keep seeing is the same one playing out in millions of households across the country right now. Picture this: a man in his mid-50s, healthy weight, exercises 3 times a week, doesn't drink much. By every external measure, he is doing the right things. But for the past 2 years, he has been waking up 2, sometimes 3 times a night to urinate. He is tired during the day in a way that coffee doesn't fix. His motivation has dropped. His drive, in every sense of the word, is not what it was. He brings it up at his annual physical. His doctor orders a PSA test, checks the prostate, and finds mild enlargement, nothing alarming. The doctor mentions it is common for men his age, suggests he limit fluids before bed, and moves on to the next item on the checklist. Nobody asks about his sleep quality. Nobody asks whether he snores. Nobody asks whether his partner has noticed him stopping breathing in the night. Nobody orders a sleep study. Nobody connects the fatigue, the low motivation, the body composition changes, and the nighttime waking into a single picture. Because the guidelines your doctor follows were not built around that picture. Nobody told you that. Here is what the research actually shows, and what that exam room conversation almost never includes. Nocturia, the medical term for waking up at night to urinate, is not just a plumbing problem. It is one of the most sensitive clinical indicators of obstructive sleep apnea in men. Not a minor clue, not an occasional overlap, a major, consistent, well-documented signal that something else may be driving the waking, something that has nothing to do with your prostate and everything to do with your airway. And obstructive sleep apnea doesn't just interrupt your sleep. It interrupts a hormonal process your body runs every single night, one that most men over 50 have never been told about, and one that becomes more important, not less, as you age past 50. Nobody told you that either. And here is the part that should make you stop and read this sentence twice. If you have undiagnosed sleep apnea and you start testosterone replacement to address the fatigue, the low drive, and the body composition changes, you may be making the underlying problem significantly worse. Not slightly worse, significantly worse. That is the gap between what the research now shows and what is happening in most exam rooms across the country. And that gap is costing men their sleep, their hormones, and years of quality they should still have. Today, we're closing that gap. In the next few minutes, I'm going to walk you through the 3-part connection that explains what is actually happening when you wake up at night, why the prostate explanation is incomplete for a large percentage of men, what the research shows about sleep apnea and testosterone, and the exact questions worth bringing to your doctor before you accept any single explanation for what you're experiencing. This is education, not medical advice. Always work with a qualified clinician before making any decisions about your health care. What I can give you today is a clearer map so that when you sit down with your doctor, you're an informed participant in that conversation, not a passive recipient of whatever gets written on the prescription pad. Before I get into the first connection, the one that starts with a number that most men find genuinely surprising, how many times did you wake up last night? If the answer is 2 or more, and if you've been telling yourself it's just age, just the prostate, just what happens when you get older, I need you to stay with me through this entire video. Because what you are about to hear may completely change how you understand what has been happening every night while you were asleep. Let's start with a number that should stop you cold. More than 75% of men diagnosed with obstructive sleep apnea report nocturia as a consistent symptom. Not occasionally, not once in a while, night after night, with a frequency that most of them had already accepted as normal, as just what happens when you get older. 75%. That is not a minor statistical overlap. That is a signal so consistent that researchers have described nocturia as one of the most sensitive clinical markers for sleep apnea in men. More sensitive, in many cases, than snoring, more consistent than daytime fatigue, and yet it is almost never the symptom that sends a man to a sleep specialist. It sends him to a urologist, it sends him to a conversation about his prostate, and the sleep apnea, the thing that may be driving the entire pattern, goes completely undetected. Nobody told you that. Now here is what makes this so easy to miss and so easy to misattribute. Obstructive sleep apnea does not feel like what most men imagine it does. Most men picture someone who snores loudly, stops breathing dramatically, and wakes up gasping. Some men with sleep apnea do experience that, but a large number do not. They wake up quietly, go to the bathroom, go back to sleep, and have no memory of anything unusual happening. What they do not realize is that the sequence of events often runs in the opposite direction from what they assume. They believe the bladder filled up, the urge woke them, and they got up to urinate. But in many cases, the apnea event happened first. The airway closed, the brain registered a drop in oxygen, the body was pulled out of deep sleep, and the urge to urinate followed, triggered by the physiological stress of the apnea itself. Your prostate did not wake you up. The apnea did. A study published in the Journal of Urology tracked the relationship between sleep problems and urological symptoms in a large population of men over time. The researchers described the relationship as bidirectional. Sleep problems worsen urinary symptoms, and urinary symptoms worsen sleep. But what the study made clear is that treating only the urinary side of that equation without addressing the sleep side produces incomplete and often disappointing results. This is why so many men try medication for their prostate symptoms, see modest improvement, and still wake up 2 or 3 times a night. The prostate medication addressed one variable. The underlying sleep disorder remained untouched. And while that sleep disorder remained untouched, something else was happening, something that most men in this situation have never been told about, because it requires connecting 2 conversations that almost never happen in the same room. Write this down. Your body produces the majority of your daily testosterone during sleep, not during exercise, not during the day, during sleep, specifically during the deep restorative cycles of REM sleep that your brain cycles through several times each night. Obstructive sleep apnea systematically destroys those cycles. Every time your airway closes during the night, your brain does exactly one thing. It pulls you out of deep sleep just enough to reopen it. You may not feel this happening. You may have no memory of it in the morning, but your body registered every single one of those micro-arousals, and every one of them interrupted the hormonal process that should have been running while you slept. A study tracking 924 men with lower urinary symptoms found that testosterone levels were significantly lower in men who experienced 4 or more episodes of nocturia per night. The researchers noted they couldn't definitively establish which came first, whether the frequent waking suppressed testosterone or whether falling testosterone contributed to the urinary symptoms. What they found was unambiguous. The connection exists, it is measurable, and it runs directly through sleep quality. This matters because low testosterone doesn't stay in one lane. It doesn't just affect libido or muscle mass, though it affects both. Low testosterone is associated with increased body fat, particularly visceral fat, the fat that accumulates around the abdominal organs. And visceral fat itself is one of the strongest risk factors for worsening sleep apnea. So the loop closes on itself. The apnea disrupts the sleep. The disrupted sleep suppresses testosterone. The suppressed testosterone contributes to fat accumulation. The fat accumulation worsens the apnea. And the man waking up 3 times a night to urinate is caught inside a cycle that no prostate medication was ever designed to break. Have you ever been tested for sleep apnea? Drop your answer in the comments right now. Yes or no. That's it.
Because what I am about to show you in the next section, the part that changes how you approach this entire conversation, depends on understanding one more layer of this picture. And it is the layer that most men find the most surprising. Here is the part most men never see coming. You went to your doctor about fatigue and low drive. Your doctor ordered a testosterone panel. The results came back low or low normal, which is a range that creates its own confusion, and somewhere in that conversation, the possibility of testosterone replacement therapy came up. Maybe you are already on it. Maybe you were considering it. Maybe you have been researching it online and the information you found made it sound like an obvious next step. Before you take that step, or if you have already taken it, there is something the research is now very clear about that most men in this situation were never told. Testosterone replacement therapy in men with undiagnosed obstructive sleep apnea can make the sleep apnea significantly worse. Write this down. The mechanism is not fully understood, but the evidence is consistent enough that major medical organizations now flag untreated severe sleep apnea as a reason to withhold testosterone therapy until the sleep disorder is addressed. The American Urological Association has noted that candidates for testosterone therapy should be screened for sleep apnea before treatment begins. The Mayo Clinic lists untreated severe obstructive sleep apnea as one of the conditions that may lead a clinician to recommend against starting testosterone therapy. This is not a fringe position. This is the current clinical guidance. And yet, the number of men who walk into a testosterone conversation without ever having been screened for sleep apnea, without anyone in the room connecting their nocturia, their fatigue, their low drive, and their body composition changes into a single clinical picture, is significant enough that researchers have specifically called it out in the literature. The guidelines have not caught up with the conversation most men need to be having. Nobody told you that. Now, let's talk about what a more complete picture actually looks like and why getting this right changes everything about how you approach your next conversation with your doctor. The 3 variables in this equation are not separate problems. They are one problem wearing 3 different masks. The first mask is urological. You wake up at night. You assume it is the prostate. You get the prostate checked. The prostate becomes the focus of the conversation, and everything else gets filtered out. The second mask is hormonal. You feel tired, flat, less motivated, less physically capable than you were 5 years ago. You assume it is testosterone. You get a panel. The number is low or borderline. Testosterone becomes the focus, and everything else gets filtered out. The third mask, the one underneath both of them, the one that neither the urological conversation nor the hormonal conversation was designed to find, is the airway. It is the thing happening in the dark, while you sleep, that is driving both of the symptoms you brought into the exam room. A man presenting with nocturia and low testosterone who has never been evaluated for sleep apnea has not had a complete evaluation. He has had 2 partial ones. That is not a criticism of his doctors. It's a structural problem, one that requires the patient to understand enough to ask the question that connects the rooms. You are not a passive recipient of medical decisions. You are an informed participant in your own health. And the question that connects the rooms is this: before we treat the prostate and before we discuss testosterone, has anyone evaluated whether sleep apnea could be driving both? That one question, asked clearly, calmly, and with the specificity to make it impossible to dismiss, may be the most valuable thing you take out of this video. Write it down. Bring it to your next appointment. And if the answer you get is anything other than a direct response to the question, ask it again. In the final section, I'm going to give you 3 concrete actions with specific numbers that you can take into that conversation and into your daily life right now. Not experimental, not promising, practical, evidence-supported, and available to any man over 50 who decides he's done accepting incomplete answers. Stay with me. Let's bring this home, because everything I have shown you in the last 14 minutes only matters if it changes something you actually do. You now understand the 3-part connection. Nocturia is not always a prostate story. In a significant percentage of men over 50, it's a sleep story, and that sleep story connects directly to a hormone story that no prostate medication was designed to address. The question is, what do you do with that? Here are 3 concrete actions.
Specific, evidence-supported, and available to you starting this week. Action 1. Ask for a sleep apnea screening before accepting any single explanation for your nocturia. This does not have to be complicated. The first step is often a validated questionnaire, the stop bang, which your doctor can administer in under 2 minutes, followed, if indicated, by a home sleep apnea test. Home sleep tests have become widely available, covered by most insurance plans, and can be completed in your own bed without spending a night in a lab. The threshold that should prompt this conversation is simple. If you are waking up 2 or more times per night on a consistent basis and you have not been evaluated for sleep apnea, you have not had a complete evaluation. That is not an opinion. That is the current direction of the clinical literature. Write this down before your next appointment. I would like to be screened for sleep apnea before we discuss any other treatment for my nighttime symptoms. Action 2. If testosterone replacement therapy is on the table, make sure sleep apnea has been ruled out first. Major medical organizations, including the Mayo Clinic and the American Urological Association, currently recommend screening for sleep apnea before initiating testosterone therapy in men with relevant symptoms. Untreated severe sleep apnea is listed as a reason to withhold testosterone replacement therapy until the sleep disorder is addressed. This does not mean testosterone therapy is wrong for you. It means the sequence matters. Treating sleep apnea first or simultaneously gives the hormonal picture a chance to stabilize on its own before introducing a therapy that may complicate an undiagnosed condition. If you are already on testosterone replacement therapy and you have never been evaluated for sleep apnea, bring that conversation to your doctor at your next visit. Ask specifically whether a sleep study is appropriate given your current treatment. The number to remember here: among men with obstructive sleep apnea between the ages of 50 and 70, prevalence is approximately 40%. If you are in that age range, on testosterone therapy, and have never been screened, the math is not in your favor. Action 3. Treat your sleep as a clinical variable, not a lifestyle preference. This is the shift that most men resist, and the one that may produce the most impact. Sleep is not recovery time. It is not the absence of being awake. Sleep is an active biological process during which your body regulates hormones,
clears metabolic waste from the brain, repairs tissue, and consolidates memory. Disrupting that process consistently, even subtly, even in ways you do not consciously feel, has measurable downstream effects on testosterone, on insulin sensitivity, on cardiovascular risk, and on urinary function. The research on men who extended their sleep from under 6 hours to 7 or more hours showed measurable increases in testosterone levels within weeks, not months, weeks. The body responds quickly when the conditions for hormone production are restored. This does not mean sleep alone solves the problem. It means if you are treating your prostate, managing your testosterone, and optimizing your diet and exercise while sleeping 6 fragmented hours a night because an undiagnosed airway disorder is destroying your sleep architecture, you are building on a foundation that can't hold. Fix the foundation first. Here's your 3-point recap before you go. 1. Nocturia in men over 50 is not always a prostate story. In more than 75% of men with obstructive sleep apnea, it's a sleep story, and the sleep disorder often goes undetected for years. 2. Obstructive sleep apnea disrupts REM sleep, suppresses testosterone, and creates a self-reinforcing cycle that connects your nighttime waking, your hormone levels, and your body composition into one problem, not 3 separate ones. 3. The sequence of evaluation matters. Before accepting a prostate diagnosis, before starting testosterone therapy, ask whether sleep apnea has been ruled out. That one question may change everything that follows. If this video gave you a clearer map, drop "informed" in the comments right now. That word tells me you watched, you understood, and you're ready to have a different kind of conversation with your doctor. Share this with a man over 50 who is still blaming his prostate for something that may have a completely different answer. And if you want to go deeper, the next video covers what the latest research says about the earliest signs of testosterone decline that most men miss until the window for easy intervention has already closed. I will see you there. This video is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare provider before making decisions about medications, supplements, or any aspect of your healthcare.